Hello, everyone, and welcome to our module on tuberculosis diagnosis and treatment. In the first video on tuberculosis, I talk about the tuberculosis bacteria itself in terms of its structure and virulence factors. In this video, we're going to focus on how you make a diagnosis of a tuberculosis infection and how you treat that infection. So first of all, you always want to remember that tuberculosis is difficult to culture. So unfortunately, you can't send a sputum sample from a patient to the lab and find out if there's a tuberculosis infection a few days later. Nevertheless, early diagnosis of active tuberculosis infection is very important in order to prevent spread. It's a highly contagious bacterium. So in the first video on tuberculosis, I talk about how exposure can lead to active disease like primary tuberculosis, but it can also lead to a contained infection. This is called latent tuberculosis. The infection is still present in the body, but it's contained by the immune system and it's asymptomatic. And this latent infection can persist for years or decades or even a person's entire life. So there are a number of tests of prior exposure to tuberculosis. These are mostly used to detect latent tuberculosis. There are two important tests used for this purpose: the interferon gamma release assay and tuberculin skin testing. We'll talk about both of these in a minute. And in general, these are used to identify patients who have a latent infection. These patients are at risk for a reactivation infection, and sometimes we treat patients with a latent infection to lower their risk of ever developing reactivation tuberculosis. If we think someone has an active pulmonary tuberculosis infection, usually what we do is test a sputum sample, and there are a number of tests you can do for tuberculosis, and we'll also talk about these in this video. So let's talk about the interferon gamma release assay. This is a test that determines whether or not a person has previously been exposed to tuberculosis. Doesn't tell you whether they have active infection or latent infection, and usually this test is used to identify patients who have latent tuberculosis. The way the test works is it measures T-cell release of interferon gamma. You expose a sample of the patient's T-cells to tuberculosis antigens, and you measure the amount of interferon gamma produced. That's why it's called an interferon gamma release assay. And it identifies patients who have been exposed to TB, like I just said. This test is going to be positive in patients who have a latent infection. It's also going to be positive in patients who have active tuberculosis. And in terms of detecting latent infections, this is the gold standard blood test. It's replaced tuberculin skin testing, which used to be the gold standard, and we'll talk about that later. The reason it's become the gold standard is because it has a high specificity and sensitivity. It's more specific than the PPD testing, which we'll talk about in just a minute. It's also not affected by the BCG vaccine, which we will also discuss shortly. And so this is the best test to identify latent tuberculosis infection, and it also can be used to support the diagnosis of active tuberculosis. This test can't tell you a person has active tuberculosis, but it can tell you they've been exposed, and that makes it more likely that they may have active disease. Tuberculin skin testing is also called PPD testing, and the reason it's called PPD is because that stands for purified protein derivative, and that refers to the substance you inject in the skin as part of this test. This is generally used as a test to identify latent tuberculosis, although as I said on the last slide, this has largely been replaced by the interferon gamma release assay. This used to be the gold standard, but now it's the interferon gamma release assay. The way you do this test is you inject a small amount of PPD intradermally, meaning right in the dermal layer of the skin, and then you wait 48 hours. And at 48 hours, you examine the spot on the skin where you injected the PPD, and you measure the diameter of induration, not erythema. Let me explain what I mean by this. So if you look at this picture on the slide here, this is what the skin typically looks like after you inject the PPD substance and wait 48 hours. There will be a small area of hardened skin. This is the indurated area. And then surrounding that, there'll be a larger area where the skin is pink or erythematous. And all this is caused by reaction to the PPD derivative. What you do to determine whether this test is abnormal or not is you measure this diameter here, the diameter of the indurated skin area, not the diameter of the erythematous area. And I'll show you in a minute how you measure this area and use it to determine whether or not the patient has latent tuberculosis infection. Importantly, if the patient has received the BCG vaccine, which is a vaccine against tuberculosis we'll talk about in a minute, that will lead to a false positive result on this test. So when patients have received this vaccine, you can't use this test to identify latent tuberculosis infection. So this slide shows how you interpret tuberculin skin testing or PPD testing based on the diameter of induration. So if the diameter of induration is less than 5 millimeters, that's always negative. And if it's greater than 15 millimeters, That's always positive, even in healthy patients who have a low likelihood of tuberculosis exposure. If it's in the range of 5 or 10 millimeters, then it can be positive if the patient has certain risk factors. So, for example, if the induration is between 5 and 10 millimeters and the patient has a history of HIV or they're otherwise immunosuppressed, then this is considered a positive result for latent TB. And the idea here is that if patients have immunosuppression, they can't generate the normal amount of induration that a healthy person would, so we accept lesser amounts of induration as a positive test. And then if the induration is between 10 millimeters and 15 millimeters, we consider that a positive test only in high-risk individuals. And down at the bottom, I've shown you some of the high-risk groups. Patients who have silicosis of the lungs are at particularly high risk. So are patients with kidney disease, diabetes, IV drug users, and these other groups here. So the way I always keep this straight is that less than 5 is always negative, more than 15 is always positive, and if they're in the middle, then you have to think about whether or not they have some of these special risk factors for the test to be considered positive. Like I told you before, the interferon gamma release assay has become the gold standard for testing for latent tuberculosis infection. One of many reasons why it has supplanted PPD testing is because there are a number of groups that can have a false negative result to the PPD test. These are all groups that can't mount the immune response normally to the PPD substance. So, for example, patients on immunosuppressive drugs like steroids or TNF-alpha inhibitors can have a false negative PPD test, meaning the area of induration is very small, but they still have latent TB. And the reason the area of induration is small is because they can't mount the normal immunoresponse. Same thing can happen with patients who have immunocompromised states like advanced HIV or kidney disease or malnutrition. There are also some lymph system diseases like sarcoidosis and some lymphomas or leukemias. These things can also lead to false negative PPD results. So let's talk about the BCG vaccine, which we've already mentioned a couple of times in this video. So BCG stands for Bacille Calmette Guerin. It's the name of this vaccine named after its creators. And basically, it's a live strain of Mycobacterium bovis, which is a mycobacterium that is not virulent like tuberculosis, but it will create an immune response that provides some protection against TB. It's more effective when you use it in patients who have never been exposed to TB. So, for example, it's about 80% effective in children, but it's much less effective in adults. And that's because by the time we reach adulthood, many of us have already been exposed to TB. So this vaccine is not often used in the United States, but it's used in areas of the world outside the United States with a high prevalence of TB, and it's mostly used in children. As we already mentioned, it will create a false positive PPD test. So in individuals who receive this vaccine as a child, the PPD test is not reliable to identify a latent TB infection. But it doesn't affect the interferon gamma release assay test, so this can still be used to identify latent TB. Okay, now let's talk about the diagnosis of active tuberculosis. So imagine you meet a patient in the emergency room. They have fever and cough, and symptoms have been ongoing for a few weeks. This is what pulmonary tuberculosis, when it's active, can look like. Maybe they have risk factors for tuberculosis like immunosuppression or malnutrition. So in someone like that, you want to suspect that they could have active TB. So how are you going to make the diagnosis? Well, the usual method is to obtain 3 sputum samples. Usually you obtain them about 8 hours apart. They can be spontaneously produced by the patient, or sometimes they are induced. The way you induce a sputum sample is you use a little bit of aerosolized saline and you squirt it into the patient's throat, and it makes them cough and produce a sputum sample. You then send those 3 samples to the lab. First of all, it will be tested for the presence of acid-fast bacteria using staining, and also it will be sent for mycobacterial culture, although as we already talked about in this video, culture takes quite a while to come back because this is a slow-growing bacteria. You can also analyze the sputum samples using NAA tests, which are nucleic acid amplification tests. In these tests, a specific nucleic acid sequence that's unique to tuberculosis is amplified, and it can be detected by a probe. And so these are the main things that are done to try and identify if a person has active TB. You can also use the interferon gamma release assay or TST testing, but these only show that the person has been exposed to TB. They don't necessarily indicate an active infection. So when these tests are positive, that supports the diagnosis, but you really need positive sputum samples to confirm active tuberculosis. You should be aware that if you identify a person with active pulmonary tuberculosis, you don't necessarily have to hospitalize them. You only need to hospitalize them if they have hypoxemia or other things that make it unsafe for them to go home. For outpatients who you are going to treat in the outpatient setting, you advise them to remain at home so they don't spread the bacteria around, and to avoid visitors and to mask. When you do admit someone to the hospital for active TB and they become an inpatient, they need to be placed on respiratory isolation. The idea here is that tuberculosis, when it's active, is highly contagious, and there are lots of immunocompromised patients in the hospital, so you don't want this bacteria to spread around. So these patients are given a private room with negative air pressure so that when the doors are opened, it pulls air into the room and doesn't push air out of the room. And then visitors have to dress like these people in the picture here. They have to wear a respirator with a tight seal over their nose and mouth so that they don't breathe in the bacteria. And then in terms of treatment, active pulmonary tuberculosis requires multi-drug regimens. That's because bacteria are usually resistant or become resistant to a single drug if that's all that is used. So a typical regimen may include 4 drugs like these ones shown here, sometimes streptomycin. I'll talk later about the mechanism of action of these drugs. They're not going to expect you on the step 1 or step 2 exams to identify a specific regimen for active TB. The most important thing to know is that a multi-drug regimen is required. Sometimes so-called direct observation therapy is done where you ask the patient to take the medication in the presence of a provider who makes sure they actually take it. This is in areas of the country where people sometimes don't comply with therapy and you don't want to breed resistant bacteria, so direct observation is required. And once again, the reason you use a multi-drug regimen is because there is a risk of so-called multi-drug resistant tuberculosis if you only use a single agent, and that's why multi-drug regimens are always used. Okay, now let's talk about latent tuberculosis treatment. So we talked earlier about how you can use the interferon gamma release assay or tuberculin skin testing like what's shown here to identify individuals who have latent tuberculosis infection. What do you need to do in terms of treatment of those individuals? Well, first of all, you should know that most patients who have latent tuberculosis will not develop reactivation active TB. So even if you do nothing, most patients will not go on to develop an active pulmonary tuberculosis infection, but a small proportion of patients will reactivate. And so in some cases, we administer prophylaxis to lower the risk of reactivation tuberculosis. Some of the regimens that can be used as prophylaxis are shown here. The antibiotic isoniazid, which we'll talk about in a minute, used to be the standard. You would administer it for 6 to 9 months in patients who had evidence of latent tuberculosis. There are now some newer regimens that have emerged that are just as effective, and you don't have to take them for so many months. One of these is isoniazid plus rifampin for 3 months. Another is rifampin for 4 months. I think it's pretty low yield to memorize all these regimens. You should just know that prophylaxis is indicated in some patients, and the idea here is to lower the risk of reactivation disease. You should also know that after a patient has been treated with prophylaxis for latent TB, you don't need to do further testing for latent TB. And that's because the interferon gamma release assay or tuberculin skin testing, all of this will remain positive for life. So once they've been treated, you don't repeat the testing. So now let's talk about some of the antibiotics used to treat tuberculosis, and we'll start by talking about isoniazid. So isoniazid blocks the synthesis of mycolic acids, which are key components of the cell wall of all mycobacteria, including tuberculosis. When you expose bacteria to this drug, they lose their acid fastness because the acid-fast stain binds to the unique cell wall structure of tuberculosis, including the mycolic acids in the cell wall. There's an enzyme inside of tuberculosis bacteria called CatG-encoded catalase peroxidase that's essential for isoniazid to work. This enzyme is sometimes called CatG for short. It's encoded by a gene called CatG, and the gene product functions as an enzyme that has catalase and peroxidase activity. But the reason this enzyme is so important is because it converts INH to its active form once the antibiotic is taken up by the bacteria. And so you need this enzyme present in order for INH to work, and if mutations develop in this enzyme, then the bacteria can become resistant to INH. And this is one of many reasons why monotherapy with antibiotics like isoniazid is not used to treat tuberculosis, because eventually it will produce resistance when the drug is used alone. Isoniazid has some special adverse effects that often come up in step 1 questions, so let's talk about those now. First of all, it's potentially neurotoxic, so it can cause neuropathy, which can present as sensory loss or weakness. It can also cause ataxia and potentially paresthesias, which are numbness and tingling. One of the mechanisms by which it does this is by competing with vitamin B6 as a cofactor for the synthesis of neurotransmitters. And so for this reason, isoniazid is often given together with pyridoxine, which is vitamin B6. This maintains B6 function in synthesizing neurotransmitters, and it limits the neurotoxic effects. Isoniazid is also potentially hepatotoxic, so when patients take this drug for several months or longer, you usually need to monitor their liver function tests like AST and ALT. The mechanism of this is unclear, but is probably related to metabolites of INH. And then lastly, isoniazid can potentially cause drug-induced lupus, which leads to a malar rash like what's shown here. And I talk about lupus, including drug-induced lupus, in videos in the immunology section. Okay, next antibiotic for tuberculosis is rifampin. This antibiotic inhibits bacterial DNA-dependent RNA polymerase. This means that it blocks RNA synthesis, and that's how it leads to cell death in mycobacteria. The main side effects occur in the liver and the GI tract. Just like isoniazid, rifampin can increase the LFTs and they need to be monitored, and then it often leads to GI upset symptoms like nausea, cramps, sometimes diarrhea. A special thing to know about this drug is that it turns bodily fluids into a red-orange color. This is not dangerous, but patients will report it. So they will say that their urine looks red-orange, or their saliva, or their sweat and tears. If they happen to have a spinal tap, the CSF can even be red-orange. So importantly, this is not dangerous. This sometimes comes up in a board question. You don't have to stop the drug, but you do need to be aware that rifampin can cause this effect. Pyrazidamide is another tuberculosis antibiotic. Its mechanism of action is unknown. It's converted to a substance called pyrazinoic acid, and it's thought that this may be more likely to happen in the acidic environment inside of macrophages where tuberculosis replicates, so this may help the drug to be more effective and active. It's potentially hepatotoxic, so you need to monitor the liver function tests just like we talked about for rifampin and isoniazid. And then you need to be aware that this drug can cause gout. This is something that often comes up in board questions. It competes with uric acid for excretion in the kidneys. So when patients take this drug, they don't excrete as much uric acid and the uric acid levels can climb. This can lead to hyperuricemia and an exacerbation of gout, just like this person who has a large swollen toe on their foot. Next drug is ethambutol. It inhibits an enzyme called arabinosyl transferase. This enzyme polymerizes the sugar molecule arabinose for mycobacterial cell walls. So when you administer ethambutol, the bacteria cannot maintain their cell wall. A key side effect to know about this drug is optic neuropathy. So it can cause patients to develop red-green color blindness. You need to be aware of this. If they describe it in a board question, they're talking about a side effect of ethambutol. It can also sometimes cause patients to lose their visual acuity. This is all reversible on stopping the drug. And then the last drug we'll talk about is streptomycin. This is a very old aminoglycoside drug. In fact, it was one of the first aminoglycosides ever discovered, and the person who discovered it won the Nobel Prize because it was effective in treating tuberculosis. And at the time, in the 1940s and 50s, there were no treatments for tuberculosis. It works the same way as all aminoglycoside antibiotics. It inhibits bacterial 30S ribosomal subunits, and this prevents protein synthesis inside mycobacteria. The reason this drug has fallen out of favor is because there's lots of resistance. Tuberculosis often develops mutations of genes that code for ribosomal proteins, and that causes streptomycin to become ineffective. Okay, and then I'll finish this video with one slide on key points about how to diagnose and treat active versus latent tuberculosis. So active tuberculosis means someone who has an active pulmonary infection with symptoms like cough and hemoptysis. This could be a primary infection from initial exposure to TB or reactivation of a latent infection. So the diagnosis of active TB requires 3 sputum samples, and you send it to the lab for culture, acid-fast smear testing, and nucleic acid amplification testing. And the treatment is always a multi-drug regimen. If you're trying to identify patients with latent tuberculosis, they're usually asymptomatic. This is where you can use the interferon gamma release assay or PPD testing. And these patients are usually treated with 3 to 9 months of prophylaxis, and the goal here is to reduce the risk of reactivation tuberculosis. And that concludes our module on tuberculosis diagnosis and treatment.